Hello, everyone. Welcome to Hot Seat Season 3. I'm Omid, joining you from Tehran, and once again, so excited to be with you on this educational platform. And as I've always said, I'm so thankful for all the speakers and my dear friends who accepted the invitation and are joining us from this platform, and they share their knowledge with all of us and help us obtain better understanding in treating our cases and patients over time. And today I have a very dear friend, Dr. Minas Leventis is here with me from Greece. Hello, Minas, and welcome, my friend.
Hello, Omid. Hello. Good to see you.
Joining. Thank you so much. You know, Minas is, I'm pretty sure you all know this guy because he's one of the most enthusiastic educators I know, and I know him for many years. And I'm pretty sure you've seen his cases, at least on Facebook, because he's the one who really wants to share what he knows and want to help everyone improving and becoming better. And that's why I'm so grateful to have him on. And he have to say he's a specialist in many aspects, but one of the things that he has really worked on over the years is on raw materials. So today we have a great topic that we really didn't talk about it over the past sessions, and that's management of bone defects in the extraction sockets after wisdom tooth extraction with synthetic materials that Mina's going to specifically show us how he will deal with the cases and how he will manage these massive bone defects. And maybe it's a good beginning for some of us that we are not familiar with such graft materials or such techniques. So I'm personally super excited to see the presentation. For sure, we will have a great discussion at the end on this specific topic. So before we start, I would like to have Dr. Leventis' CV for all of them, and then I will ask him to share his screen and start the presentation. And at the end, for sure, as I said, we will have a fun discussion on that. Dr. Leventis holds a DDS 1999 in dentistry and Master Science in 2004 and PhD in 2010 in oral surgery from the Dental School of the University of Athens, Greece. In 2008, he also attended a postgrad program in periodontics and implantology at the University of Heidelberg, Germany. Dr. Leventis is currently on the faculty of Dental School, University of Athens, as a visiting clinical instructor and researcher, where he teaches under the postgrad students oral surgery, bone grafting, and implantology while undertaking extensive experimental research. He's been invited to lecture extensively throughout the world on a variety of scientific topics in oral surgery, and author of numerous articles published in peer-reviewed journals like Journal of Maxillofacial Surgery, Clinical Oral Investigations, Cheaper Oral Materials, Implant Dentistry Compendium, and EDI Journal. He's teaching dental clinicians and postgrad students throughout the UK in numerous courses, seminars, Congress lectures, webinars, one-on-one mentoring sessions, and postgrad programs. He's also involved in teaching programs of ADI, stands for Association of Dental Implantology, and is a major scientific education body in implantology in UK. Based in central London, his work and clinical research are focused on implant dentistry, oral surgery, and tissue engineering. He's a member of so many prestigious international British scientific societies. I can mention in 2012, he earned the diplomate status of the IOI, and he's an active member of the UK and a member of leading implant centers and a founding member of ICOI Hellas in Greece. Once again, I'm so happy to have you, my friend. Hot seat. And I have to say, I've never been to Greece, so I'm really looking forward to come there because it's so beautiful. You can share your screen, and I'm really...
You have to, definitely. Thank you. And of course, I would like to thank you for this invitation. It's an honor. And I would like to congratulate you for your excellent work. What you are doing is really innovative, really high quality, and thank you very much for this invitation. So now I will share my screen. And Can you see it?
It's perfect.
Lovely. Okay, so today I'm going to share with you a quite interesting topic. The reason I selected this topic is to discuss something a bit different than implants. And as my background is oral surgery and all my research background has to do with synthetic bone grafting materials, I thought that it's a good idea to share with you a couple of cases, how I treat challenging cases after removing difficult wisdom teeth, how I treat them with novel synthetics, in order to have a very good healing, but most importantly, in order to avoid the periodontal complications at the distal aspect of the second molar. And I think, Omid, as a periodontist that you are, this is a very interesting and important also topic for every periodontist, every oral surgeon, and every dental clinician. So that's me. Thank you for covering my CV. And for the next around 30 minutes, I will share with you a couple of interesting cases. And what's the important thing is that we have everyday cases with impacted or semi-impacted wisdom teeth. Many times the reason why we have those patients coming to us is because we have infections, we have pericoronitis, like in this case where the patient comes to our office uh, with a swelling. He tells us that they have some kind of infection, pain in the area, they don't know exactly what's happening. And investigating, we can see many times that we have very deep pocketing and inflammation, infection distally to the second molars. So with our probe, we can see that we have very large bone defects, like in this case. And the reason, of course, is the presence of the infected, impacted wisdom tooth. What is happening and what is essential is that we have to be careful after removing such difficult wisdom teeth, because there's lots of interesting literature saying and showing to us that if we are dealing with older patients, and older meaning, according to the literature, over 26 years old, and when those patients have an impacted horizontal or mesioangular third molar with infection, then many times it's very important that not just to remove the tooth, but we have to do something more. We have to do some kind of regenerative therapy. And the reason is to avoid periodontal problems at the distal aspect of the second molar. This is very well documented in the literature. And on the other hand, it is also important because many times we don't pay attention. Those patients, they go to oral surgeons, they go to the hospital. And imagine if a patient like that goes to a hospital, a very busy department where there are 10, 20 people waiting to have their wisdom teeth removed. Imagine that the clinicians really don't pay attention what will happen after removing the wisdom tooth. So as dentists, as clinicians, our goal is not just to get rid of the infection, to remove this difficult wisdom tooth, but we have to see a bit further in the future. And definitely we have to be considering what we are going to do for the restoration of this area. And if we manage to restore the bone after removing all this infection and the wisdom tooth, then we'll have done a very good job in preserving the periodontal status of the second molar. So like in such cases, we can see here that the goal of our treatment should be in the long term to avoid any periodontal complications distal to the second molar, as we can see here. In this case, because I used regenerative therapy, after 2 years, we can see that we have no probing depth at all. We have 2 or 3 millimeters probing depth distally to this second molar, we have very good keratinized soft tissues. And in this way, not only we treated the wisdom tooth, but we somehow saved the second molar. And as we can see the x-rays, that's what we have to do, not just focus on the surgery, because of course it's important, how to get rid of this very difficult impacted wisdom tooth, how to clean the infection, but we have to see in the future, and after 1, 2, 3, 4 years, we have to be able to reconstruct the bone in this area, and in this way, we will secure also the front tooth. Many different ways what we can do. We can use growth factors, we can use membranes with very good results. As my background is bone grafting, I spent many years looking what would be the ideal bone grafting material to use in these cases. If we look at the literature, what should be the ideal properties of a bone grafting material, we can see this paper from the team of Nicholas Lang. Ideally, it has to be osteoinductive, conductive, biocompatible, totally replaced by bone. In this way, it has to have a very good resorption rate in relation to bone formation. This bone graft should maintain somehow the volume, good mechanical properties, and ideally no risk at all of disease transmission. We believe that synthetics, they have many of those properties. The last 15 years, me and my colleagues, we have researched in preclinical studies synthetic bone grafting materials. And nowadays, we have focused and we are using resorbable beta TCP materials that are mixed with calcium sulfate or with silicate. Those materials, they give us excellent results. We have published more than 20 papers showing all the results of our clinical and experimental studies. You can find all those papers on PubMed if you just search my name. And just quickly to show you this paper, we published it in Implant Dentistry 6 years ago. And we were evaluating how the bone heals if we graft it with beta TCP and calcium sulfate. These are synthetics, these are absolutely resorbable materials, and we see that they accelerate and they enhance in a very good way the regeneration of the new bone. Just to show you these two histological pictures from our animal study, on the left side, we can see just in 3 weeks, those round brown particles are the graft, which is consisted of beta tricalcium phosphate and calcium sulfate. So we can see that we have all the particles that are surrounded by connective tissue, many cells, the red are the cells, and some new bone. And with this staining, we can see that the bone is green. Just look on the right side, just after 3 weeks, we can see how the particles of the synthetic calcium phosphate, they're breaking down, they're dissolving. And at the same time, we can see the red around the green around the particles, which is the new bone. So we can see just in 3 weeks how the bone grafting material is breaking down, it's dissolving, and at the same time, as a conductive scaffold, it is helping the body to create new, lots of volume of high quality new bone tissue. Of course, we are not doing only animal studies. With those materials, we try to see what's happening in our patients. For this reason, to take biopsies from areas where we have done some kind of augmentation with those synthetic materials. And even in our human studies, we can see how nicely those materials, very quickly, after 3 months, they regenerate lots of high quality new. In this histological picture, this is a different staining. We can see here the particles of beta TCPA calcium sulfate. This is ethos. And this red is the amount of the regenerated high quality vital new bone. And a couple of more histological pictures. This is very interesting. This is high magnification. We can see this is a particle of the synthetic, and in contact, we can see the new bone, how it is forming, how it is regenerating just in contact with the surface of the particle which is breaking down. And it's very important and interesting because it's not just the particle conductive, it's not just a scaffold, but we can see that as the particle is breaking down, we can see that the new bone is forming inside the porosity of the dissolving particle. So we can see that it's a dynamic reaction between the graft and the host. And we learn now that those materials that we are using are not just bioinert, but they are bioactive biomaterials. And this is the reason why we get so good and so quick, very high quality new bone. And if we look at the literature, we can see that those materials, the beta-calcium phosphate is also highly osteoinductive. We have very good research in the medical field. Also, we have papers from the team of Richard Myron and Daniel Boozer in dentistry, telling us also that those synthetics can serve as a three-dimensional scaffold to promote osteoinduction, which is very essential. And when we are using silicate in conjunction with calcium phosphates is a very important material in orthopedics because also it is not only conductive, but it is inductive. So we see that we can use those materials in dentistry, in oral surgery, in implantology, and in our hands the last 15 years we have excellent results. This is the paper that we have published with our experience in the topic we're going to discuss today. This is an open access paper, so if you just search it online, it's published in the journal Materials. You can find it and download it. So let me show to you what I'm doing now if I have such cases. So this lady presented with this partially impacted horizontal wisdom tooth. It was infected, it was painful. We had to remove the tooth. And we can see just in this periapical X-ray, because of the position of the tooth, it's in direct contact with the root, with the distal surface of the second molar. So in this area, we have no bone at all. If we can place our probe in between the two teeth, we can see that the probe will manage to get in around 10, 11, 12 millimeters. And the second molar has absolutely no bony support on the distal aspect. So our treatment, of course, has to focus on the extraction, but also we have to think later how all this will be reconstructed. The first key point is the minimal invasive extraction. That's why we have to be careful. That's why always when I teach my students, when I do courses, I stress out to my colleagues that it's fundamental to develop the skill of extractions. If we want to become good implantologists, good dentists, we have from the beginning to learn how to do good extractions. So we have to do a clean surgery. Always when we are operating in the mouth, we have to do clean incisions. We have to have a clean site, very good lighting. We have to work with our loops, because if we have a clean site like this one, then we can do a very good surgery. Always I try to go from the buccal aspect. I try to do the smallest flap that permits me to have good access. And in this case, I did my flap and I removed some bone to see the crown of the of the wisdom tooth. Firstly, we have to remove the crown in order to have access to the roots. So I used my surgical handpiece with a straight Lindemann burr. I cut the crown, and here is with a thin elevator how I managed to remove all this big crown that was packed in behind the second molar. That's why it creates all the defect behind this tooth. So we can see now that we can visualize the roots, and what we have to do very carefully, we have to section the roots, as we can see here, because that's the easiest way to remove the tooth without sacrificing lots of bone. We remove the tooth, and the most important thing now is to clean the infection and to remove any soft tissue. The problem is that there is lots of soft tissue hiding behind the second molar. So I use such kind of degranulation burrs that are very efficient in removing the soft tissues and in polishing the bone. But most importantly, we have to go with sharp Lucas curettes, and we have to go in there and clean all the soft tissue that is hiding distally to the second molar. If we will not remove this connective soft tissue there, then whatever we'll do will have a pocket developing distally to the second molar. So good extraction, very important, but very essential is to clean all the soft tissue. Now, when I have a patient like this lady who is over 26 years old, she was in her mid-30s, with such a difficult wisdom tooth, and also when there is no bone behind the second molar, it means that we have to do something more, something that will accelerate the bone healing, and it will help us to reconstruct the bone and avoid any periodontal problems distally to the 7. In this case, I used ethos, so it's a grafting material. It's a resorbable synthetic consisting of beta-tricalcium phosphate and calcium sulfate. So I use this material for those reasons. The reasons are that it's synthetic, it's osteoconductive, it's osteoinductive, and it's fully replaceable by new bone. That means that this material will not just be a filler, but it will serve as a resorbable scaffold to regenerate only vital bone. I don't want just to use something like an inert xenograft there just to fill the void, but I want to be sure that what I'm using, it will accelerate the bone healing. It will give me the highest quality of new bone, because distally to the 7, I want to be sure that the bone that I will regenerate will be the highest quality. And also, as an orthopedic procedure, I want all this material to be replaced by new bone. The patient came back for a review after 6 months, so we can see that we have a very good healing. What we see with those synthetic materials also is that they are very biocompatible, and they also not only helping the new bone to regenerate, but at the same time, because the body is reconstructing new bone, at the same time, outside the bone, it is helping us to have thick, good quality soft tissues. So that's just 6 months after this big surgery that we did. And clinically, we can see that already after 6 months, we have no perio issues behind the 7. We go all around with our probe. There are no pockets more than 3 millimeters. This is the X-rays. So we can see after removing the tooth, immediately after cleaning, especially in this area, and grafting with the synthetic beta-TCP calcium sulfate. And this is after 2 weeks, 6 months, 9 months. So we can see the sequence. We can see how the bone graft very quickly starts turning over, and it starts being resorbed and giving place to new bone. 9 months here, and this is the X-ray 3 years, so we can see that in a very quite non-invasive way, we just did a good third molar surgery, and then we just needed to clean all the soft tissues and very quickly, in an easy way, to inject this synthetic material, and that's it. Maybe we could have the same result using membranes, but for me, using a non-resorbable membrane, it would be much more difficult to trim it, to place it there, to secure it with pins. And not only that, after that, I would need to reopen it to remove the membrane. And always I would have the risk if a wound dehiscence happens and how I would have to deal with it. So in our experience, in our hands, we get the most predictable biologically driven results by using those novel synthetic bone grafting materials in such cases. Another case where things can be much more challenging is here we had this wisdom tooth that was the cause of the development of this very large dentigerous cyst. So again, here we have to do something, not just to remove the third molar, not just to remove the cystic lesion, but also what's the best idea, what we can do to regenerate the bone in a biological way, in a quick manner, so that we will save the second molar. And the only way to save the second molar is to be sure that all this area here will fill with new bone, with vital new bone, as quick as possible. That's the clinical view, and that's the scan of this case. We can see that clinically it looks normal. There's no expansion, there's no swelling, there's nothing really that can give us a suspicion that something's happening. But the patient had symptoms, he had his OPG, he had the scans. I decided in this case, because the cyst was already quite large, you can see how close to the nerve it was expanding. The lower border of the mandible started becoming quite thin. Luckily, the wisdom tooth is higher up in an area where we have quite thick bone, so it will be safe for the mandible at the same time to remove the wisdom tooth. So it's he's 41 years old, this patient. So the plan is exactly the same. We have to find a predictable way, a good way to remove the tooth and to reconstruct the architecture and the anatomy of the area. So I planned my surgery. In this case, I designed a larger flap. I went mesially to the second molar, but again, all my designs are a kind of buccal flap. I try to avoid going quite lingually because I'm never sure which is the pathway of the lingual nerve. So the safest way always is to do our surgery from the buccal aspect. I reflected my full thickness flap. Again, you can see that buccal, there was no expansion of the bone because of the pathology. I started with the wisdom tooth. I removed as bone as it was necessary. I found the wisdom tooth. Again, minimally invasive surgery. I have to cut the tooth in many pieces. 2 pieces, 3, 4, I don't know how many. In this case, it took me around 20 minutes to cut the wisdom tooth around in 5 pieces so that I would remove as less bone as possible. I removed the tooth, and then I went very carefully with my curettes from this area and this area to mobilize the cyst. And in those cases, because those cystic lesions are benign and they are there for a long time, they're developing a thick lining, so it's quite easy to remove it in one piece. That's what happened here. I removed the whole cyst in one piece, and that's what was left. We can see that this is the socket, and all this down here is the bone defect after removing the pathology. In this case, I used, again, a resorbable material. In this case, I used a beta TCP, which is mixed with silicate. Again, beta TCP and silicate are not only conductive, but are also inductive material, fully resorbable. So I know that here for my patient, again, I will use a synthetic material that will be 100% will turn over to bone. For the socket, I selected the material in a form paste, which is injectable. So it was very easy for me to go with this thin syringe back there inside the socket and graft the whole socket of the third molar with the beta TCP with silicate. At the bottom of the large cyst, I placed some collagen because I was close to the nerve. And on top, I filled all this big defect with large granules of the same silicate beta TCP material. So that's my grafting. In the socket, I injected the paste. In the rest of the bone defect, I injected the granules of the osteoinductive synthetic material. And why I did this? I did this to accelerate and to enhance the bone healing of this case. Just 3 stitches. Always, we know this, it's very important for the healing to use thin monofilament, high quality stitches because they will collect as less bacteria on them as possible. And this is the X-ray. Immediately post-op, we can see the loose particulate of the bone graft that is placed here, distal to the second molar. What I like to do, because everything, we know that everything is important, all the steps, the big, small steps, everything contributes to a nice healing. What I'm doing in my implant and oral surgery cases, always I need some agents to disinfect and somehow, if possible, to promote the healing. Many times we are using chlorhexidine gels. The last years I prefer to use, instead of chlorhexidine because it has some side effects, I prefer to use products that are releasing oxygen. So I'm using mouthwashes or solutions or gels, like in this case, that are used like the chlorhexidine gels, let's say, but instead of having chemicals, they release oxygen. And why this is important? It's important because oxygen is disinfecting the area, and also it will promote the healing of the wound margins, because we know that oxygen plays a very important role in all the aspects of bone and soft tissue healing. So somehow, if the patient takes the gel and every day 3 times applies the gel over the suture wound, I know that the oxygen will help to disinfect the area and the stitches, but also the oxygen will go inside the margins of the wound, and it will promote the synthesis of connective tissue, but also it will promote the reepithelialization of the margins of the wound. And this is the puzzle: good incisions, clean surgery, a bioactive, biocompatible bone graft underneath, good repositioning of the flap, good quality stitches, a gel that will promote. I get very good uncomplicated healing. In most of the cases, I get no scars at all, and I have good and fast healing. This is just after 7 days, so you can see that we did such a big surgery in the area, and after 7 days, everything looks really good. We are ready to remove the stitches. In this case, the patient was just swollen for 2 or 3 post-op. This is after 7 days when he came to remove the stitches. So we have excellent results. We did, of course, histology. It was an inflamed, long-standing dentigerous cyst. That's why it had such a thick lining. And the thick lining, of course, helped us to remove it in one piece. So that was good. And we can see here, this is after 6 months, periapical X-ray, and that's the best we can see. That was our goal. After 6 months, we see the results of our treatment, and most importantly, we have very good new hard tissue in this area, securing and protecting the second molar. These are the scans before the surgery and 6 months post-op. You can see the contrast. You can see the wisdom tooth and what he created there. The wisdom tooth created a very large cystic lesion. And by doing our surgery, by removing the tooth, by cleaning the pathology, and by using an inductive synthetic material, we can see that even just in 6 months, how much new hard tissue we managed to create. And not only that, we can see how nicely the body now is managing to reconstruct and to get back the anatomy of the area. So we can see here that mostly in the lingual aspect, the cyst had created an expansion of the bone and very thin bone. And we can see now by doing our treatment, just in 6 months, we have the anatomy again of the mandible in the lingual aspect, and the nerve is safe, and we can see how nicely we have all this hard tissue coming back. So that's the sequence, that's the treatment. Although we are talking about challenging cases, quite big surgeries in the mouth, that doesn't mean that we cannot be as minimally invasive as possible. We can get a very quick healing. We can get uncomplicated healing. We can save the adjacent teeth, and that's the benefit and the important. And always we have to think when we are going to use bone grafting materials, if we need them, in which cases we need the bone grafting materials. And always I like to use synthetics, and I like to use materials that will completely turn over to new vital bone. So closing those cases, what take-home message we can have from this presentation is that we have to be careful with difficult, inflamed, impacted second molars when they are in very close proximity with the front tooth in patients that are older than 26 years old, because just by removing them, we can get very bad long-standing periodontal problems on the distal aspect of the second molar. Okay, so this is very important. There are many ways to regenerate the bone there, but in my experience and my opinion, a very good choice is when we use resorbable calcium phosphate synthetic materials. Those materials can give us excellent high quality bone, and in this way we can avoid and we can reduce the risk of having any kind of periodontal problems at the adjacent second molar. Just by closing, I will take the opportunity to share with you, Omid, and all the colleagues that we are doing a very nice contest. So with Blue M, I'm the president of the board of the Blue M board for this poster contest. So if anyone has very nice cases, any kind of cases, perio cases, implant cases, oral surgery cases, where they use those oxygen releasing products, they can make a nice poster. It's very good, very creative. Send it to us. This is the link. And 5 people will win all the expenses paid for a VIP trip to the Copenhagen Europeriod 10 Congress. And we hope that next year the Congress will take place. And these are my details, my email, my Facebook page, my website. So if anyone has any questions, they can contact me, follow me, and that's it. And thank you very much. I hope it was educational and quite interesting. I cannot hear you.
Sorry. Thank you so much, Minas.
Yeah, okay.
My audio was off. I have to say, first of all, thank you for going through that such topic, because it's one of the important aspects that most of the dentists sometimes forget about its importance. You know, sometimes we think about only extraction, and sometimes we don't pay enough attention to what will happen to the second molar. And sometimes patients come back with sensitivity, with residual pocket depth. And, you know, we want to do another surgeries, we will lose more tissues, you know. And that was one of the most key elements that you mentioned. Also, from this platform, I also want to have a shout out to Blue M, because I have to say I'm a great fan. And, you know, it's not commercial, but it's reality. When something works and when something is good, we have to say it. We all practitioners, we all educators. And, you know, when we see differences, we have to say, and people can experience, and they can feel how it goes. And actually, it was the topic of today, but you beautifully showed in your last case that how it can enhance the tissue healing. And, you know, my experience, especially in cases when I utilize time meshes or non-resorbable membranes, it really helps faster healings. And when we educate our patients in first 1 or 2 weeks, we can see it works more properly and the healing seems to be better. So I think it's a very good choice in our treatments. So Minas, one of your cases showed that you have a usually cyst around the third molar, and it was very close to the inferior alveolar nerve. And, you know, in one of the cuts of CBC, it also seems that maybe the nerve is involved in the cyst. So I want to know, you mentioned that when you cyst, you place the potty type of beta TCP ethos in the extraction sockets, and you put a membrane and you filled it with the granulated bone graft on top. First of all, I want to know, is it possible to heal the whole defect with the potty type ethos, or, I mean, beta TCP? Why did you use the combinations?
In this case, I didn't use ethos. This was bone. Ethos has beta TCP and calcium sulfate. Power bone has beta TCP with the silicate.
With the silicate, yeah, yeah.
Very similar.
Yeah.
Similar materials. Now, close to the nerve, I just placed collagen fleece, not a membrane, just collagen. And the reason was I wasn't sure how exposed the nerve was. And I didn't want to have any risk the bone graft to come in contact with the ball of the nerve. In my opinion, and from all the animal studies we have done, we haven't seen problem even if the bone graft, the synthetic bone graft, will come very close to the nerve. But it's better to be on the safe side. So at the bottom, I took many sponges, and I filled the bottom of the cavity with those collagen sponges to be sure that they will cover any exposed part of the nerve. On top, I selected to use the big granules because it was a very large cavity, and with less material, I managed to fill it quickly. So let's say I used 2 cc of granules, while if I had to use the paste, I would need to use more than 5 cc's. Mm-hmm. So it was a matter of logistics. I don't believe that I would have a different result. I went with the paste in the socket, again, because it was much quicker to take the syringe and to access back there the socket. Much more difficult for me because the wisdom tooth was impacted, but it was migrated horizontally. So in order to pack the granules in there would be quite difficult. So I took the syringe and just did the paste. In front where I had all the large bone defect, it was very easy just to open a bottle of 2 cc of large particles and just fill it. So the selection of the materials had to do how easy it was in my hands to go inside the socket up there, and how easy and quick with less material to use the granules to fill the big defect. Yeah. But both the paste and the granules, both are silicate beta TCP. It was just as less material as I could in the easiest way.
And you know, one of the things that I want to know your experience on that, about the materials that the extraction sockets or such defects adjacent to a root of the tooth. Did you find the attachment of the graft material to the root surface in the future? I mean, in your experience with the synthetic materials, because sometimes we have a distal root of the molar, and you place the material adjacent to the root and you pack it. So I want to know, do you find attachment on the root surface in the future, or did you find any differences between this type of material and other types regarding the attachment and bone formation adjacent to a root or not?
That's an excellent topic, and unfortunately, we have no data regarding this. Mm-hmm. So in those cases, there's no bone at all. We have bone regeneration, but we don't know histologically how this new bone gets attached. Is it creating a ligament? I don't know. Because we have to find a way to design an animal study in order to get sections and see what's happening. Technically, is that we have no pocketing at all in the long term.
Yeah.
But my friend, this is an excellent question, but I don't have the answer. I don't know if we have ligament.
No, maybe as long as the bone formation,
if different materials.
Yeah, maybe as long as we see the bone formation and we don't see any pockets, that's enough for us, because at least we know that the whole area is regenerated, and that's the point. And you know, one of the things that sometimes I received question regarding that, and it was also my own question, that when we use the pastes of any kind, one of the concerns that usually practitioners have, for example, in a specific amount of that paste, how many percentage is the material and how many percentage is just silicate? And if that silicate also acts as something regenerative, you know, for example, if you want to use half a cc of granulate particulate graft, or if you want to use half a cc of paste, will they act as the same regarding the amount of material is involved in the paste or not?
Definitely there are differences, because even if you have the same material, you have to create a paste or granules different. Let's say to make a paste and to have the consistency of a paste, you have to add something more, an element, a chemical element that will give the paste form. And then the other thing that is changing a lot is the macroporosity of all this bone graft. So theoretically, if you have two similar bone defects, and in one defect you will use the paste and in another you will use the granules, the regeneration will not be exactly the same in a theoretical level if you do histology. From what I see clinically, I don't see any differences. Let's say I use those silicate TCP materials for sinus lifts. Many times I use the paste because it's easier when I do a lateral sinus to inject the paste, like Nova Bone, like those materials. So I use this Power Bone, that's the name of the silicate material, injectable for lateral sinus lift. Other times I use granules because I don't have the paste, I have the granules. I have never seen any difference radiologically or with the timing of healing. I don't see clinically difference. But the answer is that histologically there must be differences because you have different macroporosity, different microporosity, you have other elements. But clinically, in my opinion, there is no difference at all.
And maybe also it depends on the type of the defect.
And
because, for example, if you want to use it in a vertical and horizontal combination defect, definitely maybe the granulate wins. But in contained defects, maybe we don't clinically. And you know, one of the other things that I want to it's just the idea. Actually, I tried it for 3 times only. It was like an experience, but I think we can talk about it. It's right, but sometimes maybe we can think about it. Just wanted to know your thoughts because you talked about wisdom teeth. Sometimes we have third molars that are not very properly positioned. And for extraction of them, we need to remove lots of bone. Or at least the act not that easy. I want to know, what do you think if that we only cut the crown and remove the dent and graft the site, but maintain the roots in the area and let the bone form and there will be a root. Do you have any experience on that? And do you think if there will be any disadvantage by remaining that white down there?
What you are describing is widely used. We call coronectomy. So there are many cases that you don't want to be so invasive. You don't want to remove so much bone, or you are afraid of damaging the nerve. So what we are doing exactly is we open a small flap and we adjust the crown of the tooth. But what is happening is that you don't have any problem. You leave the roots and you don't have the crown to block the whole tooth there. The roots start to erupt. So it's very probable that after a few years, you will need to do a second surgery of the roots because the roots will start moving. Now, how far they're going to move depends on the roots, the anatomy, the body. But it's very probable because they will find the space, they will start moving.
Yeah.
So even if you remove just the crown and graft it, you don't know what will happen with the roots. If the surgery is very risky to have a complication or something other, then yes, the best idea is just to remove the crown and monitor it. But you have to it's very probable that we will need a second additional surgery to get rid of the roots. But this coronectomy is a widely used practice, and it helps us avoiding damaging the nerve.
Yeah, yeah.
In my experience, because that's my job, and I avoid the coronectomy. In most of the cases, I try to remove everything, even if it's quite close to the nerve. But always we have to be one step before what we think we can do. We have to be very, because things happen and we see how many complications happen, and the worst thing is to damage a nerve.
Exactly. Exactly.
So what you do to me, I strongly advise clinicians, if they are not that confident when they remove a wisdom tooth, just to remove the crown instead of struggling to remove the roots and creating more problems. And then if needed, the roots will come much higher up, and then it will be very, very easy to remove them after a few years.
Mm-hmm. And Minas, I have one final question.
So always we have to be careful, yes.
Yeah, sure. Sorry. I have one final question, but it's not regarding the wisdom teeth, but I really want to know your experience on the paste of beta TCP. I want to know your experience on using that in the gap management in immediate implants. Because you recommend it. I mean, is it okay to save the space for us and prevent the collapse, or it's fast resorbing and you're recommending it in that specific areas, especially in the aesthetic zone?
That's an amazing topic. Right now we are writing up a clinical study. So we are evaluating exactly that. We have the experience that we never had problems in the aesthetic zone doing this. We don't have problems. Theoretically, the material will resorb, so it might collapse. So what we see is that with immediate placement or even with early placement, it's the same. You have a socket. When we just place and then we graft with resorbable, with ethos, never had problems. The contrary, just doing this, such an easy procedure, what's happening is that it happens something different. It's not the logic of PET or the logic of using BIOS, which is absolutely rational, but the logic is I preserve the root or I place something that will stay there, so I keep the volume. The logic, and it works. What we are doing with ethos or with other synthetics is we don't want to preserve the volume. We create new bone buccally. So we see that very quickly we have new bone, and this new bone, because it's high quality bone, it's covered by soft tissues. That Peter Fairbairn was saying when you did the hot seat. The key point is to place the implant and load the implant, because what's happening is that the loading of the implant as a system is sending the forces to the new bone buccally, and the new bone is getting activated, is turning over, and because you keep using the implant and you keep loading the bone, as a result, the bone becomes thicker and stays there because biomechanically is activated. I play tennis. As long as I play tennis, my bone here is strong and thick. It's simple orthopedic biomechanics. So what we have seen, and this is our honest experience 15 years now, in all our immediate or early implant placement cases, where, very importantly, place the correct implant, not place a very wide implant, a nice narrow implant at the positioning, meaning not too buccally. And we just graft it with beta TCP and calcium sulfate because we get so much good bone. Of course, there are localized favorable defects. This good bone will get activated and will give you better soft tissues, and it will keep the volume. Although the concept is not the traditional, ITR concept or the PET concept, in our hands and in many other clinicians' hands, it works perfectly. And this biomechanical activation of the bone is what keeps the volume. Right now, we are carrying out a study. We are using those Invert implants. It's the Southern Invert. It's the design by Stephen Chu, that he designed this different shape that it's in the apical and the middle part to give you stability, and the neck is narrow. So these are ideal for immediate placement because they give you a fantastic primary stability, and the neck is narrow, have lots of space to do your dual zone or our grafting with synthetics. So it's me, it's Peter Fairburn, it's Costa Nicolau, and it's Domenico Huli. So we are 4 clinicians. We have gathered many cases doing that. Invert implant, grafting. Even if we don't have buccal plate, we just grafted with beta TCP calcium sulfate with ethos, immediate loading. We have follow-up up to 3 years with scans, and it's really surprising how stable and aesthetic results we have. It's different concept. Always, it's what you like to do, what works in your hands. Let's say we see amazing results with PET. I have never done PET. It's not my comfort zone. What I say to my colleagues is what you like to do, what you feel comfortable, and what's your ideas. But what you said, we are working with synthetics, we get really good results. Yeah. And I think the key factor is the biomechanical action of high quality bone. It works.
Exactly. And I want to add something. I think you will agree with me. When we say synthetics, or when we say allografts, and when we say xenografts, I think the quality of each kind of them is also important. So when we say general synthetics, I'm pretty sure that not all synthetics works the same, and those kind of materials that you mentioned, and I've seen the things like you, I mean the beta TCP with the calcium silicate in phosphate, and the paste that you introduced. I think quality of that material is also very important in definition of how successful it can be. So we cannot say generally synthetics works all the time, but I think we should be more specific on the choose of the material.
You are absolutely right. I'm working with bone grafting materials 20 years now, since I took my degree. I have developed, my PhD was with allogenic materials. So I took animals and I created at the lab my own animal allogenic to do my PhD. I mean, my experience is, my field is huge with bone grafting materials. It's exactly what you say. Even the same category of materials, it's totally different. It's totally different. You cannot say that all xenografts, not even close. Or we see this with human allogenic bone, totally different properties. And it's exactly that with synthetic, the chemical composition. But most importantly, how they are made, how they are sintered, what's the particle size, what's the macroporosity, the shape, the microporosity, the other elements. It has calcium sulfate. How much? How at the electron microscope look those particles? It has silicate. How much? It's 1%, it's less. And it's exactly, you cannot say all synthetics work. No way, no way. It's the specific material, the specific application, and then of course it's also your hands and the body of the patient, how it heals. It's a puzzle, it's so many factors. But you are absolutely right. We cannot, in a generic, simplified way, say that synthetics are better than that, or we have to be specific, and always we have to try to know what exactly we are using, where we are using it, and how. It's a bit complicated, but at the same time, it's a bit simple.
You know, Minas,
it's fascinating. It's fascinating. Just
go ahead.
Just bone grafting. It's a huge area. Just bone grafting, and still, Omid, I have a PhD. I have done hundreds of surgeries just for preclinical studies. I have done 20 years, thousands of clinical cases. I have published. My friend, don't have the answers. Every day we learn, and we have to be humble and modest, and we still learn. We don't have the answers. It's our science. It's not an exact science. We try to learn what's happening.
And I think it's a fun part of
the
it.
Most important.
And you know, it's a fun part of it because we always are looking for something new, and every day is more exciting for us. We see new things, and when we see new changes, and even when we see different responses by different patients in different techniques, I think that's the fun part of it that keeps all of us going.
Exactly. It's fascinating. We learn every day. We learn from what we are doing. We learn from our clinicians. And you know that even better than me, when we teach, when you do a lecture, when you do a hands-on course, it's not that you are lecturing. In reality, you are learning. It's amazing.
Yeah, absolutely right. Minas, I have to.
So the amazing thing that till the last day, we will be learning till the last day we'll be doing dentistry. That's the beautiful thing.
Exactly. Minas, it's always great talking to you, and I'm pretty sure if we go to more, we can talk about it for hours and hours, and I know your time is also limited. I want to thank you so much, my friend, for joining me and for time and precious presentation. I really enjoyed talking to you as always, and really looking forward to this pandemic ends and we travel, we see each other, we can have more fun. And definitely, as you said, I truly recommend everyone interested in the poster competition by Blue M, collect your cases, and not just for the competition, at least you try that material if you're not yet, have a more faster, better healing for your patients. And at least we can hopefully be in Copenhagen next year and enjoy beautiful Denmark and Europe Area 10.
Let's hope so.
Thank you.
It was my pleasure. Thank you so much.
Thank you. Take care.